All right, so it's 9 o'clock, so I'm gonna start us off with a welcome. Shatanshu and Louise, you're co-hosts of the meeting, so if you would watch for the waiting room and let people in just while I'm talking, and then I'll take over looking at that. Okay, so excuse me, welcome. I'm Vanessa Aaron, the Gynecologic Oncology Project Manager for MOQC. I met everyone last fall. I've been here since August of last year. So some quick welcome information and housekeeping to start us off. If you open the participants window in your Zoom screen and your first and last name are not listed, then we don't know you're here. We'll be reaching out to you via the chat feature throughout the meeting to identify you in that case. Okay, so we will ask that you remain muted throughout the presentation until we open it up for discussion. But Louise Bedard, who you all know, she's the program manager of MOQC, will be monitoring the chat. So if you have questions, go ahead and put them in the chat window so that we can address them. To mute and unmute yourself, there should be a microphone, typically in the bottom left of your screen. If there's a diagonal line through it, you're muted. If there isn't, then we should be able to hear you. All right, so this is a quick look at the agenda. We included it in your materials and in your emails, and so I'm just going to let you glance at it for a brief second, and then we'll move on. Okay, there are CME credits available for this meeting, 3 of them. The information on how to collect those credits is included in your electronic materials, and you're also welcome to reach out to me, email, call, anything works if you run into any problems. I'm now going to shift this over to the co-director of MOQC, Shatanshu Uppal.
Okay, can everybody see my screen? Vanessa? Good, okay.
Yep, all set.
That's wonderful. Okay, now I'm assuming that you're seeing the wrong screen.
That's true.
Here we go. Better?
Yes.
Okay, so Vanessa has already talked about the agenda, but briefly, I'll go over some of the measures from the last 6 months time frame and a few updates in the last few months since we met. And then Vanessa and Audra from the state of Michigan will discuss with our partnership with the state and the state grant, which CDC gave us. And Dr. Griggs is going to join us a little bit later for a family history grant discussion in detail, and then we'll open the floor for open discussions. So just to give everybody an update, we've had 16 practices which were included. For this round, there were 12 practices which were where the data was abstracted. This has steadily increased. If you notice, every time I've shown this slide, more and more practices have been added. For the next round, we will also have 3 or 4 of the Beaumont practices which will be included as well. We're just trying to work some of the agreements and just getting the data abstraction started in these practices. So hopefully we'll get to the point where we'll have everybody in Michigan who's practicing GYN oncology, their data is abstracted. So this is a slide worth looking at. As time has gone by, I hope that we are in this dotted square now. From network building to getting the data and measure, and then planning and strategy. And I'm banking that people have enough trust in MOQC now that we can start working together and doing some impactful work. This is where the sentiment changes from skepticism to trust to intellectual engagement and collective pride. I think to get to that last point of collective pride, we really have to put out data, publications, and put it out there that what we're doing as a cumulative, as a collective of GYN oncologists in the state is something very unique in our practice. So just to remind everybody, for the round 2 of 2019, the charts were abstracted between July 5th and December 3rd, 2019. This is also in this table, there's a description of what COPI, which is the platform we use from ASCO, what are their metrics of the cases to be included. If you notice, some of the dates over here go way back until 2018, but majority of these patients qualify because they've had a diagnosis of cancer and a visit, 2 visits with the physician within July 5th and December 3rd of 2019. And then there's a group of patients where I'll show the metrics of end of life. These are the patients who died within this time frame and had 2 visits within the prior 9 months with the physicians. So this is important to keep in mind as we look at the trend of some of these data. So just before we go there, this is something we've discussed before, but it's worth talking about again. Something in the future we have to look at is full transparency at the meetings, meaning unblinded data. Many of the CQIs have moved into these phases, and this comes with an enormous amount of trust, and also in some ways we have to respect each other, where if the number is lower in a certain practice, it's not because the person in that practice doesn't know what they're doing. It may be the patient population is different, or maybe the resources are not available to get that metric to be where it needs to be. But this is which is really important, because we can look at each other's numbers and say, I see that your numbers in this particular area are not as good as they can be. Let us share our resources and improve those metrics. Peer-to-peer review and coaching. This is something worth discussing in detail in our brainstorming session. 2 of the CQIs, the bariatric surgery and urology, which is MOQC Collaborative, have started this process where surgeons are submitting their videos voluntarily. Obviously, the patient data is not included in those videos. And they've created a platform where you submit your video and your peers will critique the video and say, you can improve your technique by using this instrument, or the way you've, approached exposing a certain plane, you could do this. They share their own video saying, look at this video and see how this makes your life easier, port placement, et cetera, et cetera. A lot easier in laparoscopic surgery. It's complicated in open surgery, but at least it's a good starting point, because majority of our practices are either doing laparoscopic or robotic hysterectomies. CQIs do improve outcomes much faster than the clinical practice changes with the evidence-based medicine. Our bariatric surgery collaborative just presented some data on utilization, or actually de-escalating the utilization of the IVC filters, which was a routine practice before bariatric surgery. CQI got together and they found out that actually patients who were getting the IVC filter had a higher mortality. In evidence-based medicine, sometimes they've shown the level 1 data takes about anywhere from 10 to 17 years to percolate into the practice, but here they were able to change that within a time frame of about 12 months. So any of the quality improvement things, or any new evidence coming in which is changing the practice, we can use this platform now that everybody's a part of that, saying, okay, I really think that we ought to do this in all the practices in Michigan. We can make some rapid changes using this platform. Addressing appropriateness is another big one. We've talked a little bit about this. This again will depend a lot on trust. There are a lot of procedures and imaging studies being done in our cancer patients, which sometimes I understand is hard because the patients are particularly interested in getting a Q3 monthly scan to see their cancer is not coming back, but they're not all of these practices are supported by data. So if we, as a collaborative, put out our own guidelines saying, obviously there are exceptions to the rules, but for majority of these patients, we are going to do imaging studies on X, Y, and Z intervals, and put a lot of asterisks and saying, obviously the clinical judgment precedes all these. But my feeling is that when we do that, overall rates of imaging studies will go down. Including the voice of the patients, and this is a big one. We have not historically included, well, when I say we, the GYN oncology part, since we were in a phase of trying to build this collaborative. But I think moving forward, we should get patients to this meeting. My understanding is we have one patient who's already a part of this meeting. We'll introduce her later. Patient engagement is super important, and I think patient-reported outcomes, which was basically the whole topic of discussion for the last 2 years until we got derailed by COVID. New and pressing concerns, I think developing guidelines based on the data which is coming from ASCO. For example, in my mind, one of the topics which I keep looking in social media and through emails and correspondence with the people I'm in touch with in GYN oncology community is how should we utilize PARP inhibitors, for example. There's a lot of data coming out using the PARP inhibitors on the front line. People have concerns about using these drugs for maintenance therapy when there's only progression-free survival improvement and no improvement in overall survival. I feel if we all got together and come to a consensus, it would be a lot better if we all had a similar practice pattern in this. It's less confusing for other practices, for example, medical oncologists who are looking for guidance in some of these patients. This would be super helpful. So these are some of the things we can talk in detail during our open question and answer session. So moving on to the important aspect of this meeting, which is the performance measures. There's a lot of stuff on this slide, so I'm going to go point by point. So let's just focus on first the measure about pain addressed appropriately by the second office visit and during most recent office visit. So you can see this number has consistently increased. So I put a little happy face right there. So we are roughly around 93% of the patients where this is actually not only addressed, but appropriately documented in the chart. And I think that's the key part. I feel like we do it in 100% of the cases, but sometimes the documentation is not reflective of the practice. But we've done a lot better since we've started from 77% to 93%. Now, this measure is a little complicated, and this is complicated because ASCO's platform does not consider PARP inhibitors as chemotherapy. Now, this metric would be very, very useful if PARP inhibitors were considered in oral chemotherapy, but our data collection only focuses on primary therapy of ovarian cancer. So as you can imagine, majority of the patients are getting carboplatin, Taxol, or a combination of any, carbotaxol, Avastin, et cetera, but there's no oral chemotherapy drugs being used in this setting. If we change this to PARP inhibitor, then, adherence will become an important metric. But again, the issue is that we're collecting only the primary therapy. Again, PARP inhibitors being used in primary therapy is a subject of debate, as I mentioned before, and it's very recent that the studies have come out even showing progression-free survival improvement. Signed consent for chemotherapy, I think this is great. We've gone from 90 to 95% of the patients. Again, many of the institutions have made this mandatory, at least at the university. Our nurses will not give chemotherapy until the consent is signed. Sometimes it delays the chemotherapy until somebody actually walks down to the infusion center, makes the patient sign the consent, but it has significantly improved the process of chemotherapy consent signing in our patient population. And it seems like it's similar across the state. This is a measure where we were doing great, and then in round 2, the numbers have gone down. Again, the number of patients in here are low. So there's a lot of, the confidence intervals are really wide. So it's 1 or 2 patients on either side can make a huge difference in the percentages. But overall, I think this number should be around 100%. If we identify somebody as a smoker, the data now is very strong that smoking while receiving chemotherapy or radiation actually reduces the overall survival. So I think this is something where at least documenting in the chart that we've given this piece of information to the patient is very important. I typically acknowledge with the patient that I understand that your stress level is really high and this is a really difficult time to quit smoking, but you really have to do it because your chemotherapy or radiation is going to work a lot better. And that somewhat helps cancer. They're very motivated with the cancer treatment. So I think this is an opportunity where we can all improve our outcomes. This metric has become relatively not so useful or useless for us because in our setting, if we're collecting data on the upfront therapy, platinums are included, both carboplatin greater than equal to the AUC of 5 or cisplatin are included in the high hematogenic risk. So almost every one of our patients when NK1 receptor antagonists are given are appropriate based on the guidelines. So I think this measure might be something we may not need to collect in the future. Or going back to this measure again, we collect it if we move on to a phase where we are collecting quality metrics of chemotherapy in a recurrent setting, somebody receiving single agent Doxil and getting amend with that would be an inappropriate use of it, but we're not there yet. Again, with infertility risk discussion prior to chemotherapy, our numbers have significantly improved. My feeling is that this number was always good because in GYN oncology, when we are talking about giving chemotherapy, oftentimes hysterectomy, oophorectomy are also discussed in the same discussion topic, and infertility invariably becomes a topic of discussion. It's just that we've become better at documenting is my feeling, but we can definitely get this metric to 100% moving forward. Again, the numbers are low because luckily majority of our patients are not in the younger age group. So moving on to the EOL measures, I think there's a lot of room for improvement over here. If you look at the pain and dyspnea addressed appropriately, I think this is, our numbers are high, but can be better. Again, I feel like this may be both, either we are not addressing it or we are not documenting it. Either way, not documented is equal to not done, at least in the world of quality improvement. So I think this is something we should put a lot of effort in. We have come a long way because this number was, somewhere around the range of 60 to 70%, and now it's consistently around 84%. So I think a lot more can be done. My feeling is templated notes can help a lot with this, and discussion with the patient as they progress with these metrics in some sort of checklist would be super helpful. The hospice and palliative care measures, if you look at the hospice enrollment within the last 3 days, lower score is better. This number has changed a lot and actually is rising, meaning people are spending time in hospice for less than 3 days is increasing, which is not great. So we're sending them to hospice, we're sending them hospice late. The hospice enrollment or documentation of discussion has increased, but I'll be honest with you, I haven't gone into the details of this metric to see how many of them were actually hospice enrollment and how many of these were actually documented discussions only. What really matters in quality improvement sometimes is a measure where we're not just measuring the process, but actually are measuring the impact of that quality improvement intervention. And in this case, the actual number of patients who are enrolled in hospice and enrolled in hospice for more than 3 days. Longer the better. And a very related piece to this is the metric over here where chemotherapy administration has happened in the last 2 weeks. Now, some patients do not want to be enrolled in hospice. They have family members taking care of them and they just do not want hospice involvement during that time. But if we are actively administering chemotherapy in the last 2 weeks of their life, then that tells me that there's a big disconnect here. The number is low, but still rising. And this number is very consistent with the number we found looking at the national data sets of chemotherapy administration in SEER Medicare data. And in GYN oncology, this number is about, roughly double the number in medical oncology. So moving on to the genetic testing and counseling. Unfortunately, we have data missing for one of the rounds. We're still looking for where the data went. but we'll eventually find it. But the reality is that these numbers have we've done really well in these numbers. But I just want to emphasize that this is genetic testing and counseling. So we are not actually picking up how many patients who were sent for genetic testing and counseling actually underwent genetic testing. That will be the next phase of data collection for this, and that's the number which matters. We've seen, I could talk a little bit more about the University of Michigan experience. We've seen that, from majority of the patients, like 95% of the patients who are referred, the actual testing numbers are somewhere around 50 to 60%. For a host of different reasons, people keep dropping at different time frames. And Dr. Griggs is going to talk a little bit about family history grant, which has ties to genetic testing and counseling. I'll let her explain all that, but my feeling is we'll be able to capture this data in a lot more detail moving forward. Now, if you remember this other metric, which is very specific to GYN oncology, we've been collecting in the last 4 rounds, is the days between cytoreduction, the first day of chemotherapy. I personally really like this measure because it's one measure which is actually very meaningful and collects a host of information, even though the information is not collected directly. Now, if you're more aggressive in your surgical efforts than you should be for a frail patients, this number will be higher. If the care coordination in a practice is not great, the number will be higher. So it captures a bunch of things together. We know from the data published from National Cancer Database, the Northwestern group from Chicago has published this data that anytime this number is above 28, we start to see a decline in overall survival in these patients. And that was true for patients with primary debulking. That's true for patients with neoadjuvant chemotherapy, more so in primary debulking than in neoadjuvant chemotherapy. But again, we should be just to keep things simple, we should keep one day, which is 28 days, as a measure. To look at our own data, the median is around 28, mean is around 30. So meaning half the patients are still, it takes longer to get them chemotherapy after their surgery is done. So we've had prior discussions about this measure in some of the practices. The patients are getting chemotherapy with a medical oncologist. You send a referral. By the time the referral goes in, the patient is seen and actually gotten the chemotherapy, it's already more than 4 weeks. So I think having a conversation with those practices and trying to advocate for our patients to get the chemotherapy sooner would be something I'll strongly encourage you to look at. Okay, so this is the last quality improvement data slide I have. This is a project, if you all remember, about quality improvement in our operative notes. Now these numbers are only focusing on ovarian cancer surgery. And the idea was that there were these elements we had put out on the MSQC website, which included the state of the stage of the disease, whether the patient was optimally debulked or not, whether the debulking was primary debulking or interval debulking. And then we had put a little calculator from Mayo Clinic, which is validated in ovarian cancer debulking patients, to capture the complexity of surgery, and it spits out a score which would help us in future looking at, in terms of data adjustment and risk adjustment of these data. So the step one was to have everybody use the calculator and put all these elements, but these numbers haven't really improved over time. So we are hovering around that 60-65% mark. We've done a few things to improve this number, but have a modest improvement. If you look at different practices, you can see that there's a wide range in how compliant the practices are with putting all these elements in their operative notes. There's some practices which have, putting these pieces of information in almost every single operative note. And I think it's worth, when I talked a little bit about unblinding the data, it'll be worthwhile, from our side, we can reach out to site number 5 and ask them, what are they doing to make them more compliant? And I think distribution of the ideas, dissemination of the ideas from this particular site to everybody else will be super helpful. Now, we've done a few things from the MOQC site to increase this metric. So if you remember in 2018, Dr. Barry Rosen did a presentation where he showed this very elaborate operative note template built into their EMR system when he was in Toronto. The problem with that, it was a great system, but implementing that in Michigan would be difficult because we have so many different electronic medical records. We discussed the data and we revamped the website, put a checklist on the website, hoping people will go onto the website and do it. And then we've also developed some templates. This is new this time, and I'm gonna go open this website right now. So if you wanna bookmark this, put it on your mobile device, we've actually redesigned the checklist. So I'm just gonna click this and show everyone how this looks. So if you go on that link, moqcoperativenote.org, so it's easy to remember. It's not .com, it's .org. And you click on this online operative node generator. It will open up this template. So you can pick ovarian, cervical, and endometrial. So I'll just give you an example of the ovarian cancer. So you have to go through primary or interval debulking, enter the stage of the patient. Now, if you hover your mouse over it and wait for a second, it'll give you the detail of that staging. So if you're in the operative node and you're thinking to yourself, what stage should I assign this patient because of these new FIGO staging system, you can look at these staging systems right here and then pick the patient, the appropriate stage. Now, I acknowledge that in primary debulking surgery, sometimes this will not be readily available to us, but go ahead and put your best guess during that time. So if you're gonna call this patient, possibly a 1A or 1B, but later on the lymph nodes come out to be positive, it's okay. As long as the staging information was done with the best possible information available to you, that's what we're looking for. Modality of surgery, and then the residual disease. And if it is suboptimal, there's a little box over here to enter the size and location. So if I was suboptimal, which never happens to me, but I could just say, 1 centimeter node on the periodic, something like that. And then you will just go ahead and click the procedures you've done, for example, THBSO, omentectomy, pelvic periodic lymph node dissection, rectosigmoid resection, splenectomy. So you can see the score is 9 here, compared to somebody who's only done an interval debulking with THBSO omentectomy, their score will only be 2. Once I'm done with all this, you say generate operative note. Agree the fact that this is, you're responsible for making sure that information is correct before you put it into medical records, not the MOQC. Once you agree, it gives you this text-based stuff over here, and you could just literally copy this and paste it into your EMR, whether it is Epic or Cerner. It will work with every single one of them because this is just text. So if you're writing a brief op note, your resident is writing a brief op note, your fellow is writing a brief op note, if you can point them to this website and they can copy and paste it at the end of the brief note, or if you're the person who's dictating or typing the notes, you can just do this in the real time and you'll be able to enter all the data. So I'm going to spend 2 more seconds in endometrial cancer. Now, we're not collecting the data on endometrial cancer at this point of time, but maybe if we are changing behavior on entering some specific information, we might start with all this. The modality for endometrial cancer, you'll say, whether you did laparoscopic or robotic case, and you'll say full nodes. And if you did full nodes, you'll specify, did you do pelvic, periodic, or both? And if you did sentinel lymph node, the system will show you where the site mapped. Now, this is tricky. Where the site mapped is always a question of debate. I would, and I think I can email everybody the paper where Dr. Hanna was a co-author on the FIRES trial. There's very specific definitions of what is characterized as an obturator node, what is characterized as an external iliac node, and there's a little diagram there which we can use just so that it's consistent that we are all picking the same node. For example, a node can only be called obturator if it was in contact with the obturator nerve. And we can, let Dr. Hanna explain a little bit more later if there's any issues with this. But you pick the nodes on the right side and the left side for sentinel, and then whether pelvic washing was done or not done. Now, this is also collecting data on how many times your lymph nodes are not mapping. So if you look at the FIRES trial, about 15% of the patients did not have any mapping. 85% of the time the mapping was at least on one side, and 50% of the time the mapping is on both sides. So we can use that as our baseline measure and see if any practice where sentinel lymph nodes are being done and you find yourself that you map only about 60% of the time, we can compare the techniques with other practices where mapping rates are higher. We can share videos or maybe even arrange for one of us to come in into each other's operating room and look at how we inject and what are the techniques we are using for sentinel lymph node mapping. So this could increase the number of successfully mapped lymph nodes in the entire collaborative. And similarly, cervix cancer, again, there's staging up here. And same with the ovarian cancer. If you hover your mouse over there, it'll give you the details of the staging. And histology, grade, whether it was done open, laparoscopic, robotic, or vaginal. If you click robotic or laparoscopic, there'll be a big warning sign popping up. No, I'm just kidding. It's still available to people if they want to do it, but it's a little bit problematic. Ovaries, whether they were transposed or not, and again, the same with sentinel lymph nodes, the details of sentinel lymph node, if you're using sentinel lymph node in laparoscopy, in open procedures, which I understand is a challenge. So please use this operative note. Again, the link over here is moqcopnote.org. We've also created some lab code pocket cards if that's what you prefer. If you're somebody who dictates your notes and going to a website in the operating room is just not feasible for your workflow. And my understanding is that we'll mail these to your practices. They're laminated and you can throw it in your lab code. So one other thing we are doing is that moving forward, we will use the operative node measure for value-based reimbursement. Now, if you remember in the previous meeting, we had Blue Cross Blue Shield team members come in and explain how the value-based reimbursement works. So I won't go into details of all this. If you have questions about VBR, just send us a note, and we're happy to talk more in detail about that. But OpNote will be used as a measure for quality improvement. We've not set a target for it yet, and I think this is something which the measures committee should collectively decide. It's not for me or MOQC to decide, but all of us to decide that where do we want this number to be. We are around 67%. Can this number be taken higher, maybe 75, 80% to get value-based reimbursement? Okay. So moving on to our project, which we are working on and have been working on for the last 6 months, is the post-operative outcomes. So if you remember very beginning of MOQC Gynecology, one of the things I've always been interested in is capturing post-operative outcomes. We've experimented with different ways of doing this, whether we collect the data in a database ourselves or participate or partner with another collaborative. At the end, it made more sense to participate in a collaborative fashion with MSQC. MSQC is Michigan Surgical Quality Consortium collaborative. They're very similar to MOQC, much bigger than us. There are 2,500 surgeons, including colorectal, breast cancer, and most of the general surgeons, and I think bariatrics is separate. They are included in this, and gynecology is included in this. So they collect data on surgical outcomes 30 days after the surgery is done. But there are certain issues with MSQC which doesn't allow us to use their data directly right this minute. One of the issues is that MSQC currently samples the data. What that means is that they're not collecting every single surgical case we do in our practice. In Michigan, University of Michigan, they come for the first 7 days of a month. And these days are different for each practice. So if you're somebody who only has operating room time blocks in your hospital, let's say the second, third, and fourth week, your data will be not captured in this. Or maybe 1 or 2 cases you've done on an off week will be captured. So what we are trying to work with MSQC is to actually, instead of sampling, collect all cases for GYN oncology. So if a case is associated with your name, they'll collect it. Whether the patient has cancer or not is irrelevant. as long as you're the surgeon, they'll start collecting all the cases you're doing. And that will be super important to us, because then we will have a much higher number of cases to look at surgical outcomes across different sites. We're hoping that this is in place and the data is collected in spring of 2021. We do have the approval of Blue Cross Blue Shield, and MSQC agreements are done. And data elements is what we're working on right now to make sure that whatever MSQC is collecting, we agree with that, and the choices are what we need in there. But I do want to emphasize one thing, that MSQC is collecting data on each one of us through our hospitals already. So if you go to this web page, and I'm going to log in with my username and password with this right now, but if you request access, if you go to this website, let me just open it up here. There's a big, there's a username password, and then there's also a button over here to request your access. Now, everybody is going to have the pleasure to see me enter my password, and it will come out to be wrong. I tried to save it, it didn't work. So it almost invariably will be an incorrect password. Oh, success. Okay, so this is how this data looks like. So I'm going to show you my own data. Now, I'm not authorized to show anyone else's data to anyone, but this is my own data, so I can share this with you. The red bar are my outcomes. Blue bar is University of Michigan outcomes compared to my peers, and green is MSQC as a whole, as a collaborative. Now, you can look at these numbers from different time frames. So you can see, you can look at particular year. You can say in the last 12 months or 24 months, and you can actually look at a specific year. I can see, how are my numbers in 2018, for example. So you can look at each one of these in detail and see if your outcomes are improving or not improving. The other piece, which is interesting over here, is that you can also look at these data from a couple of different angles. You can see if these cases were non-emergent, which is majority of our cancer cases. And then you can also make sure that you're talking about inpatient or outpatient cases. So I'm just going to look at my inpatient cases, and you can also filter by whether these cancer patients have cancer or not. So now this is a more real comparison between gynecologists in the state of Michigan, because majority of the inpatient surgery with patients who have a diagnosis of cancer is done by gynecologists. So you can see, you can compare any morbidity. You can look at serious morbidity, mortality, surgical site infections, serious surgical site infections, sepsis, length of stay, emergency room visits, readmission rates, reoperation rates, and UTIs, pneumonias, VT, and anastomotic leaks. So this is, you can play around with this and look at your data right now. So the link I showed you previously, if you go on that link, we'll send that link to you in an email. You can go in and request access. You'll be able to see your own data over here. So some of the other folks in MSQC who are surgeon champions in your hospital will have access to all the surgeons in that particular practice. So they'll be able to see data of a lot more surgeons, but you'll be able to see your own. The other piece which is important here is that there's a little dashboard here which can show you some other metrics. One of the ones which we are interested in is opioid prescribing. So if you remember the last meeting, we did a little bit of a quick and dirty data collection of MOQC surgeons, and all of us were doing fairly well in the amount of opioids prescribed. But MSQC is already collecting that data for all the patients who are undergoing surgery, and we're hoping that from sampling this goes to all cases. So you can see this data in a few different ways. You can look at this particular area over here. It can show you the average number of pills prescribed, and you can look at the number of pills prescribed by me, by my peers, and this is the MSQC as a whole. Again, I think there's you can filter these down by laparoscopic hysterectomy and abdominal hysterectomy. What they do not have, they don't have a filter here for cancer cases, because my feeling is that this includes, the green bar includes all abdominal hysterectomies done, whether it is done for endometrial cancer, whether this is done for a patient with sarcoma, where they have pelvic sidewall extension and they were already on opioids. And as we all know, patients with cancer have more psychological needs right during the surgery period, and opioid use is affected by it in some ways. So it's not a fair comparison to compare this with somebody with fibroids to somebody who is undergoing surgery for cancer cases. You can also look at laparoscopic hysterectomy and look at the amount of pills prescribed. I like this one more because I'm doing better in this. So you can look at these numbers and sort of play around. Again, these numbers will be more meaningful when we have data on all cases instead of just sampled cases by MSQC. And if anyone has trouble getting access to this as a surgeon, just throw us an email and we'll talk to the MSQC team and get you the access. Okay, so in summary, there are three things we need to address. The first one is that these measures, for a host of different reasons, which I mentioned before, should be retired, is my proposal. In some of them, we're doing, like pain, we're doing great. Oral chemotherapy is irrelevant unless PARP inhibitors are included. And then the last one is the NK1 for reasons I explained earlier, and similarly the infertility. There's not a whole lot of room for quality improvement if you only have 3 or 4 charts in each round of abstraction. The current value-based reimbursement measures, the operative note and days from surgery to chemotherapy, are what we are proposing to be the value-based reimbursement measures for this year. And the numbers need to be set, and please look out for either an online meeting or a phone call to discuss what this number should be. I do not want to be the only person who's deciding what the quality metrics should be. And it would be ideal if people from all the regions and different practice patterns are in that call, so they can say, okay, this seems to be a reasonable number to hope for and get to. And then we can decide that this is going to be our metric. And once we submit this to Blue Cross Blue Shield, every practice which goes above this is eligible for a value-based reimbursement. There are some other criteria. This is not the only criteria. For example, attendance to the meetings and dissemination of the materials discussed in MOQC meeting to the rest of the team are also other criteria. Luis and Vanessa can give you more details about VBR if you need to. The other piece we need to discuss is the future value-based reimbursement measures. So one of them is the opioids, which I think is very timely, but at the same time, we had difficulty collecting these data. MSQC is already doing it based on their platform. Once they collect all cases, we should be able to use this to set some quality metrics and use that as a value-based reimbursement measure. Now they also have, as I showed, surgical site infections, readmissions, reoperations. Some of these metrics are difficult to implement as a quality improvement. I've written about the problems with readmission as a metric in quality improvement. If you're an aggressive surgeon and spends a lot of time doing a 6 to 8 hour debulking, this person has a much higher rate of readmission compared to somebody else. So, but in the long term, that benefits them in terms of their survival, but immediately the readmission rates are higher. So I'm not very fond of readmission as a quality improvement project. But surgical site infection certainly can be something we can look at. And reoperations is another area to focus. I think from a utilization perspective, one big area we should be focusing on is emergency room use, not just the readmission. So lots of patients are going to the emergency room for things which can be solved either by prospectively addressing them or by having a structure where a nurse is calling the patient on day 2 or day 3, or bringing them into an office for a post-operative visit sooner than what many of the practices would do. So I think lots of different ideas, but these measures can be used once we have consistent data for about a year as baseline data, and then we say, okay, we need to move our metrics to a certain desired level, and then that becomes a VBR. Okay, so from my side, this is about 15 minutes earlier than what my allocated time. So if people want to ask questions, we can send the questions through chat or unmute yourself. I think there's a raise your hand feature. Okay, so Vanessa, are you guys, I'm going to stop my screen share for now. And I think there's a raise your hand feature or the chat. If there are questions, I'm happy to take, and Vanessa and Louise can help me with answering those questions as well.
Yes, that's correct, Shatanshu. Both Vanessa and I can manage the questions for you. Vanessa, will you people understand how to unmute themselves? You go to the left-hand side of your bottom of your screen. You have a little microphone that has a line through it. You just click on that to take the line away, or you can chat. So Dr. Hannah, you have a question, or 2, or maybe 3. Go right ahead, Dr. Hannah.
Good morning, guys. Upal, always amazing to listen to your thoughts and ideas and your leadership. A couple of things you mentioned in the earlier in the discussion. One was about looking at different sites and see why their stats are low in certain categories. I think it's an amazing thing to talk to these different sites or different surgeons in these sites. The one thing that I'd like to ask is, how are you going to navigate the, for lack of a better word, the ego of people, okay? Because I can tell you from experience, even when you present the data in an academic way, they are stuck. Some people might be stuck with a certain understanding or a certain training. So that's one thing. The other thing, the idea that you shared about the urologists sending their videos and looking at their colleagues and kind of critiquing them in an appropriate manner, I think that's a great idea. Do you think we'll start doing that soon? And how are you going to navigate the legalities of recording videos? Because working as an expert witness, and I can tell you one of the things that I wanted to do with my group was, in my robotic committee at Henry Ford, with all the surgeons, was to mandate video recording. In addition to the logistics of finding a platform to upload those videos, the one thing is, if there is a complication, how would we navigate that part of sharing that video with the law firms, etc.? Thank you.
No, this is great. So I think I'll address the second one first. Luckily, we don't have to reinvent the wheel. We can just, collaborate with music and bariatric surgery collaborative. I know they have an online platform where you actually go in and you upload your video. It's as long as there are no patient identifiers on it, the HIPAA doesn't become a problem, and this is my understanding. I can't speak as to the legality of it because from their standpoint, once you remove the patient identifiers, then connecting it back to the patient is difficult. Although I have to say that in music, one of the
Okay, it's 10:15, so if people wanted to wander back to their computer screens. And before we jump into the next session, I know Dr. Gogoy had a question for Dr. Upal, so I wanted to read that to the group. Thoughts about DVT prophylaxis for patient with neoadjuvant chemotherapy as a quality measure?
Okay. Yeah, I think that I think Dr. Gogoy is back on. Yeah, that's a great suggestion. I think this is something which we can collect relatively easy because we know the chemotherapy patients who are there, and then we could do the Corona score, which the AVERT study used, and in that particular study they used oral anticoagulants, apixaban. So it doesn't matter what we use as long as something is used in neoadjuvant chemotherapy patients who are eligible. That's a great suggestion. We'll keep that in mind.
Okay, great. And also before we start in on our next presentation, I'd like to take a second to say hello to the two MOQC members that we have with us today. So Amanda, are you back at your computer? Did you want to say hi? Amanda Itlion?
Sure, good morning.
Hi, Amanda. And then the other MOQC member we've got with us is Sharon Kim. Sharon, are you out there?
I am. Good morning, everyone.
Thank you both for coming. We very much appreciate it, as always. Okay, so we are going to jump into our next presentation. Okay, can someone confirm for me that they're seeing the correct screen?
Yes.
Perfect, thank you. All right, so once again, I'm Vanessa Aaron, the Gynecologic Oncology Project Manager at MOQC. I'll be giving you the updates on our partnership with the state that we introduced in our fall 2019 meeting, along with Audra Putt. She's with the Michigan Department of Health and Human Services. I'll let Audra tell you a little bit about herself.
Good morning, everyone. Thanks, Vanessa. My name is Audra Putt, and I'm the palliative care consultant for the MDHHS Cancer Prevention and Control section. And I've been looking forward to presenting with Vanessa this morning because this is a grant and project that we've been very excited about and are thrilled that we can come and give an update about the wonderful progress that's been made.
Perfect. Okay, thank you, Audra. So at our last biannual meeting in October, Debbie Webster, who's also with us today, she's with the Department of Health and Human Services as well, presented on a partnership between the state of Michigan, MOQC, and MOQC to increase the number of women seen by gynecologic oncologists in the state of Michigan. Need for this project was based on the gap between new diagnoses of ovarian cancer in the state and the number of charts MOQC has located to abstract. The found cases also includes patients who've left the state. Blue Cross Blue Shield can provide us with those numbers. Ovarian cancer, as everyone is aware, usually has late stage diagnosis. So certainly part of that gap can be explained by patients passing away before they have a chance for an appointment, but the gap is still too large for that to be the only reason. This grant is meant to increase awareness and education and help streamline the process for getting patients into a gyn onc practice so that we can decrease that gap. Okay, so just as a refresher, the projects that were approved under the grant were a patient navigation hotline that will be manned by an employee of the state, reference checklist for primary care providers, OB-GYN providers, and patients with suspected ovarian cancer, and an educational podcast for newly diagnosed ovarian cancer patients. We'll be updating you on where each of these projects stands right now and the next steps. Okay, so patient navigation line. We took the information that you provided us at the last biannual and developed materials for Angela, the state representative who will be manning the hotline. She'll have access to an interactive map of the gyn onc practices that will allow her to plug in a patient's address and pull up the nearest practice. She'll also be able to advise patients on likely insurance participation, but since that information changes often, she'll make sure that the patient knows to confirm. We've also developed a series of script sheets for her so that she has some guidance on 101 information about ovarian cancer. Again, we did that at a work group that I'll mention again in a second. Her recommendations will be based on location unless the patient has a specific practice preference outside of the nearest options.
And one other thing I'll add to this slide as well is a little bit of an update and some background about how we're going to be like promoting and advertising the patient navigation line here at MDHHS. So we've been communicating with the MDHHS communication office and talking with their subject matter experts about, developing a plan about how we can promote this patient navigation line in Michigan. And the plan was originally set to roll out late spring, early summer, but as you can imagine, things came up with COVID-19 and with what the communications office has been focused on, we knew that we were going to have to delay that a little bit. So we've been in talks with them and hopefully we'll be reconvening with them in upcoming weeks to figure out when we're going to roll out our plan for that this summer. With initial discussions, one thing we did discuss was the focus on using social media as a way to develop or promote this patient navigation line. And so we're going to be meeting with them, as I mentioned, to kind of figure out what that's going to look like. And we're excited to finally kind of have a timeline for when that's going to roll out as we are kind of still focused on COVID-19. And additionally, along with the patient navigation line and promoting it with the communications office and our kind of social media plan, at MDHHS, we're also going to have an ovarian cancer website, which is exciting. And so we'll be promoting some of like the materials we're developing through this project. MDHHS was also developing a patient public education document related to ovarian cancer and working with gynecologic oncologists. So that's something that's going to be promoted on there as well. And then also we'll be sharing the patient navigation line with our additional partners and through our Michigan Cancer Consortium, which will be something we'll do this summer too.
Okay, so physician and patient checklists. So in February, a small work group, which I mentioned a second ago, consisting of volunteer physicians, a nurse practitioner, and MOQC staff met in Lansing to develop the materials we presented at our last biannual. Thank you to everyone who was there. There are a couple of them here today too. And the physician checklist is meant to provide PCPs and OB-GYNs with the most pertinent information needed to send a new patient with suspected ovarian cancer to a gynecologic oncologist, the gold standard. It also stresses that the results of all tests are not necessary before a referral is made. The patient, excuse me, the patient checklist is meant to provide patients with a roadmap to help them navigate their care as they transition from a PCP or OB-GYN to a gynecologic oncologist. The hope is that it will become an information resource sheet for them to help streamline the most important information that they need. Those checklists were then sent to the state for additional changes and taken to patient focus groups, with which Audra can tell you a little bit about.
Yeah, I'm excited to report that the patient focus groups were actually just completed a couple of weeks ago. And as Vanessa mentioned at the beginning of the presentation, one of our other partners with this grant is MOQC, the Michigan Ovarian Cancer Alliance. And so we worked with them to kind of like coordinate and recruit for the focus groups. And when everything came up with COVID, we weren't sure if we were going to be able to do the focus groups, and we're trying to figure out kind of what next steps were because, as you understand, we're not able to bring patients together at this time. So we worked it out and we're actually able to do the focus groups via Zoom, which was one of the first times here at MDHHS that we facilitated that number of focus groups virtually. And we were thrilled that, there was still a high level of participant engagement even via Zoom. And so we held 3 focus groups throughout the state, 2 in urban areas and 1 in a rural area. We had a mix of patients, those that were going through active treatment and those that were post-treatment, which was wonderful. And along with the patient checklist, they also reviewed that public education document that I referenced earlier. And right now we're still working through the data and reviewing it and coding everything. But what I can report at this time is that it was generally very positive feedback about the documents. And, it's always exciting to take those documents to the patients because, you want to take them to the audience that they're intended for. And we always learn something new and are thrilled with the feedback we received. And so hopefully we'll have that to MOQC within a couple of weeks so that we can start making edits and kind of wrap that up early on in the summer.
Okay, great. And then once they're finalized, Shatanshu will be presenting the checklist to PCPs, the physician checklist to PCPs and general surgeons utilizing the Blue Cross Blue Shield PGIP group. He'll also be requesting time on the agendas for other CQI groups, such as MSQC and OBI, to reach out to those physician populations. The patient checklist will be a resource distributed by Angela as a part of her script for the patient navigation line. Practices are also welcome to reach out about physical copies of the checklist that you can have available in your individual clinics. You can request that your logo be incorporated into the checklist in place of or in addition to the MOQC logo, and we'll ship them straight to you. So this is the physician checklist. It's in your electronic materials to review, but this is just a little snapshot. It will also be available on the MOQC website once it's complete. If you have some time, please review it for content. Don't worry about the aesthetics. We're going to be sending it to our marketing team to make it look professional. The patient checklist, as Audra mentioned, will distribute once they've finished incorporating that patient feedback from those focus groups. Okay, the final project we've been working on as a part of the ovarian cancer grant is an ovarian cancer education podcast for patients and loved ones. We have agreed to one finished episode as our deliverable, but we've started recording content for 2 episodes. New diagnosis is the first, treatment options is the second. A warm thank you to Dr. Radhika Gogoi from Karmanos for volunteering as one of our first physician experts for the new diagnosis episode. We're currently editing that, and I'd like to play you a sample beginning. Fair warning, it's approximately 7 minutes long. It may not be the final product, we're still working on it, but it will give you an idea of the direction that we're heading. Welcome to the Ovarian Cancer Podcast, a podcast centered around a cancer diagnosis and what that means. A podcast created to help physicians and patients learn from each other, connect, and share stories and knowledge. Today's episode will focus on new diagnosis and the basics of ovarian cancer. I'm Vanessa, and I'm joined today by my guest moderator, Rachel.
Hello.
Hi, Rachel. We're going to talk to ovarian cancer survivors, Emma and Bev. They'll tell you a little bit about their stories and what they learned going through their journeys. Dr. Radhika Gogoi from the Karmanos Cancer Center in Detroit and Dr. Shatanshu Uppal from Michigan Medicine in Ann Arbor will also be joining us. They are gynecologic oncologists, which are doctors who specialize in cancers located in female reproductive organs. They'll help us understand a bit more about ovarian cancer, and Rachel and I will help fill in the gaps. If you're listening to this podcast, there's a good chance that you or a loved one has been diagnosed with ovarian cancer, which can be a scary and uncertain time. This podcast will help provide information and insight, but there are also a wealth of other resources out there for you, and we've included some of those in the show notes for this episode. Let's get started.
Can we talk about what kind of symptoms people experience that might make them nervous?
Of course. Emma was only 26 years old when she knew something was wrong.
It was the summer of 2015, and I think it was around June that I was in a yoga class, and I was doing a little bit of a back bend and lying flat on my stomach, and I could feel kind of I don't know, it's hard to describe, but something didn't feel right. It kind of felt like there was, of course now I would call it a mass, but I didn't have the terminology to describe it. It was just, I noticed that something was a little bit different. There was kind of a tightness in my stomach, and it wasn't, and that was easy to ignore for a couple months. And then as time went on, I thought that I was gaining weight. And I always think back, my mom used to tell me growing up that eventually I would hit an age, in my late 20s or early 30s where my metabolism would slow down. She was like, and you'll gain weight, it's something that'll just inevitably happen to you. And so of course, as I'm gaining weight inexplicably to me, because I was exercising and eating well, I figured, well, maybe this is it. Maybe my metabolism is slowing down. But it was getting to a point where it just really didn't make sense to me anymore, where, I really thought that I was eating really well, probably the best I had ever eaten in my life diet-wise, and I was exercising really consistently, and it just seemed like I was continuing to gain weight, but in a very specific place and in a very specific way. And my stomach was very hard. It wasn't really wasn't squishy like you would normally expect your stomach to be.
Bev's experience was also confusing for her.
So my first symptoms that brought me to my primary care physician started with stomach pressure, soreness in the abs, kind of like doing 100 setups the day before. I had, at the same time, I had started a cleaning business. So I was doing a lot of extra mopping and sweeping, and I thought maybe that was the reason for the soreness. But the soreness, it just didn't go away. So then some of the other symptoms that I had, I began to bloat, finding myself really like looking for different tops, larger tops to kind of cover the bloatiness. And then, I don't know, I just knew something wasn't right at that time. There was a point where I couldn't eat because I would feel full, even just like 1 or 2 bites. And I love to eat, so I knew right then that something was not right.
I don't feel like eating sometimes when I get stressed, and I'm always struggling with my weight, so I don't know that I'd even think of something like ovarian cancer.
That's definitely part of the problem. Dr. Gogoi can tell us a little bit more about symptoms.
Unfortunately, most women do not have symptoms of ovarian cancer until the cancer has spread to other parts of the abdomen. So symptoms would include bloating, feeling full, abdominal distension. Some women have other GI symptoms like diarrhea or constipation. Pain is generally uncommon with ovarian cancer. And ovarian cancer is then generally detected either by imaging, for example, an ultrasound or a CAT scan, and confirmed with either a biopsy or surgery.
So I wouldn't go straight to a gynecologic oncologist, though, if I'm just wondering why I can't lose weight or why I'm sore all the time, right?
No, you'd go to your regular doctor first, that's true. Those symptoms don't always mean you have cancer, so your doctor would probably have to rule out some other things. Eventually, he or she would probably start to worry and either draw blood for indicators or do a scan to see if there's a mass. Based on those results, as soon as ovarian cancer is suspected, a referral to a gynecologic oncologist should be made as soon as possible.
Yeah, that makes sense. It seems like the general symptoms could take a while to figure out.
Dr. Gogoi and Dr. Upal agree.
Because symptoms of ovarian cancer can often be mistaken for other causes, about 3 out of 4 women will present with advanced disease. That's disease outside of the ovary.
We see 2 different kinds of presentations of ovarian cancer patients who end up in our office. One where patient has a mass on the ovary or both the ovaries, but there's no other area where there's any abnormality on a scan. They may or may not have elevated tumor markers, especially CA-125, which is done in this setting. And then the second group of patients we see are the ones where they may or may not have the ovarian mass, but they also have disease which is in their upper abdomen. In these patients, it is possible that somebody actually attempted a biopsy and they may or may not have elevated CA-125 again. So those are the 2 typical scenarios we see where patients are referred to us.
Okay, so that was our clip. We're hoping to have this episode complete in the next 2 months so that we can start working on the next podcast episode, treatment options. Feel free to provide feedback. That's always welcome. And we still do need a physician expert, a couple of volunteers for the treatment options episode. So if you're interested in participating with us, it's a good opportunity for exposure. It would require about an hour and a half of time for the interview, and then the possibility of an extra half an hour if additional content is needed during editing. When these episodes are complete, there'll be open access to share with any patients or loved ones. We'll share additional details about how at our next biannual. Okay, so just to review, for the patient navigation line, we included the intake coordinator contact spreadsheet in your electronic materials so that you confirm your data by June 5th, which is this upcoming Friday. We also included the physician checklist. Feel free to send in your feedback, and once we've incorporated that, we'll send it to marketing. For the podcast, please reach out to me if you'd like to volunteer for the treatment options episode. We are not above pestering people. We're developing a list of interview questions so you could see what we'll be asking in advance to prepare. We can interview remotely, so you just need a little bit of time and a quiet space.
And I just wanted to say, you know, thank you again to everyone, MOQC and all the providers gathered here for today for having me and allowing me to come with Vanessa and provide an update about this grant project. You know, here at MDHHS, this is something we've been very committed to, and we're thrilled to have received this funding from CDC, and especially this kind of grant for the first time. This was a big deal for us, and we're just looking forward, you know, to the rest of the year with the continued progress that we're going to make, and you know, the wonderful resources that we're going to have for patients along with the providers that care for them. So thank you.
And a huge thank you to Audra for joining us today. And if you have any questions, I'm going to stop screen sharing for a second and open the floor back up because we've got a few minutes before our next break. We tried to incorporate quite a few breaks because nobody wants to be sitting in front of the computer for 3 hours straight. Any questions?
Actually, this is Sharon. So I have a question about kind of the referral process. It's just referrals to help people find a provider. Is there going to be anything to help patients in terms of referral to like behavioral health providers or like support groups, things like that?
The hotline is centered more around specifically getting patients faster access to a gyn onc in hopes that those resources, I think, would be available once there.
Okay.
Audra, do you agree?
Yeah, Vanessa, I was just going to add, yeah, that's definitely kind of the focus is on the gyn oncs, but that's not to say that, you know, we would be able to like refer a patient to like some of the different like resources that we've collected on some of our other websites that may have some information about that. But primarily the focus is going to be on the referral to the gyn onc.
So Vanessa, this is Debbie. You know, just like you have scripts that have been developed to kind of guide the navigator through the you know, kind of gynec specific questions, there's a whole separate script that's been written, you know, that covers what do I do about insurance, what do I do about, you know, transportation, you know, what do I do about some of these different types of things. And we haven't necessarily included mental health at this point, but I think that's a good idea, and we certainly can get that added.
Okay, I appreciate that. Thank you. And just one other quick question about the focus group. Can you tell me about kind of the demographics of the focus group?
Yeah, in regards to demographic, so what we collect, like the information wise, was those who were like active versus like kind of post treatment. And so that's what we had. And we knew there was a variety of those type of folks involved in the focus groups based on like the conversation and what they shared. But in regards to like race and ethnicity, that was not something that we collected.
Okay, because I just think if you're doing a focus group, that type of perspective is important, because depending on the communities they're coming from and cultural, I know the cultural conversation is different, and how they access care is different.
Yeah, that's,
I just like to keep that in mind. Thank you.
Yeah, thank you for that. Yeah, and that's definitely true. And we do know the focus groups were done in different areas of the state, like in regards to rural and urban. So there was some differences in some of the information collected and some diversity in regards to that, but we didn't like specifically ask the question or ask people to identify what race or ethnicity they identified with.
And just, I mean, it's beyond race and ethnicity too, honestly, because, you know, age will have a factor, culture will have a factor. Whether or not they have a support system will have a factor, kind of things like that. Their responses and their, I mean, what they share might be different.
Yes, that's very true.
Amanda also put in chat, and I think this is really helpful. Don't forget that getting new patients connected to MOQC through the tote bag program connects them to many important additional resources. Thanks, Amanda. Okay, any other questions, thoughts before we head off to our next break?
Vanessa, we are maybe 5 minutes ahead, so want to meet at 11 or 10:55?
Let's go ahead and meet at 10:55. If everyone is okay with that?
Yeah, because if we get done earlier, then we can, give everybody their time back.
Absolutely. All right, we'll see you back here at 10:55. Okay, so it's 10:55. So if people want to start wandering back to their computers.
Vanessa, I think we need to ask Dr. Brader what his doggie's name is.
Dr. Brader, are you out there?
What was the question?
What's your dog's name?
Oh, that's a cat, actually.
Oh, Louise saw fur and thought it was a dog.
Yeah, it's Gary's his name.
Gary, what a great name for a cat.
Yeah, like SpongeBob's pet. So.
Well, that's kind of fabulous.
Yeah, he's outside now. He likes to sleep outside during the day, so he's sitting on a cushion out there sleeping. So.
I have two. I have Chubbs and Katie. They have both been banished from the room for today.
Yeah, he worked his way in. I didn't know he was in here. So, but he likes a little affection sometimes. So.
They usually do.
Yeah.
Well, Kevin, I'm going to give Gary half credit for attendance.
Oh, good. Yeah.
Okay.
He needs some credit. He's been a bad boy lately, so that'll help him a little bit. So.
Is he sitting out in the sun?
Yeah, he sits. Yeah, he sits out more in the shade, but he likes to sleep. He goes outside a lot.
Okay. Well, we do give credit to animals if they attend virtual meetings. We're very animal friendly.
Well,
so
that's good.
if Gary would like to attend, if our next meeting is virtual, because we're still in the virtual the COVID environment, you just let him know that if he needs some credit in the household, he can attend the whole meeting.
Yeah, I'll let him know. Yeah, he definitely needs. He usually needs credit in the household. So.
Okay. Well, you let him know he can get some credit by attending.
Yeah, I will. I'll let him know.
Okay.
Yeah.
Yeah.
I'm not. Yep. Thank you.
All right. No problem.
My cat Chubbs obviously likes food, which is why his name is Chubbs. And so he definitely got into the garbage and went after our pulled pork scraps last night. So he's also in trouble.
Yeah, I know that. Yeah, it's funny. They love that the food we eat. My cat's like that too. He's always trying to get in stuff. So.
Yeah, they are rascally.
Yeah, they are.
Okay, so we are going to move into our next presentation, which is Dr. Jennifer Griggs. She is obviously the director of MOQC, and she's going to tell us a little bit about the Family History Grant, which has a slightly different name, but we've simplified it here. Dr. Griggs?
Good morning, everybody. It's really nice to see all of you, and I know you're probably getting a little bit weary, so I'm going to keep this brief and I hope interesting, and I'll ask a couple questions in the chat. So if you haven't used the chat feature, see if you can find it. So we were recently awarded a grant from the National Cancer Institute. It's one of the moonshot grants. So this is a pot of money that was legislated for advancements in cancer. And my name is here, but this is a very large group of investigators. Hang on, my screen's not going down. Okay, great. So the real title is awfully long: Innovative Approaches to Expand Cancer Genetic Screening and Testing for Patients and Families in a Statewide Oncology Network, that's us, through community, that's us, state and payer partnerships. So Elena Stoffel is one of the PIs. I am, and Ken Resnick. Dr. Upal is a co-investigator, and we actually have quite a large team of people with different expertise. There will be input. We just started the grant June 1, which hasn't even happened yet. So we will be, of course, incorporating patient and caregiver voices as we usually do. And I'm pleased that Debbie is on the phone, because Debbie's been our contact for so many of our joint activities between MOQC and the Michigan Department of Health and Human Services. So this is the state partnership, and then Blue Cross Blue Shield, of course. So this is, as Louise just put in the chat, for medical oncology and GYN oncology practices, and you'll see why in just a second. So again, the team's much bigger than this, but I didn't think it was all that helpful to introduce people you didn't know. So there are gaps and barriers to genetic testing. Look at the fun I've had with PowerPoint. So in terms of identifying gaps in genetic testing and counseling, we know that only a fraction of people who are eligible for genetic assessment, which includes both testing and counseling, actually receive the care. So of those eligible, it's probably about 3% of people who are sent for screening. That's different with ovarian cancer, because in ovarian cancer, one doesn't have to identify selection criteria. I believe this is standard of care in all patients with ovarian cancer, but we have huge gaps in other cancers. One of those is we don't take a good family history. In the medical oncology practices, we are seeing a complete family history taken in about 10% of patients. And just to define what a complete family history is, this is identifying all cancers in patients in first and second degree relatives and the age of diagnosis. So this would be if the proband, let's say, is the 42-year-old with colon cancer. This is a pretty good family history, but I don't see the patient doesn't appear to have a child, but this is a Lynch syndrome pedigree. And we don't get the kind of information that we need, including the age of diagnosis, in most family histories. Another barrier, of course, is financial. People have barriers to receive genetic counseling and testing, and that not all insurance covers counseling. You have to meet certain criteria. And unfortunately, the payers are not always up to date with the guidelines. So I'm going to ask a question. What is a cancer for which we now recommend genetic testing in all patients? Can anybody enter that in the chat? This is a brand new guideline. I'll give you just a couple minutes to find the chat. Pancreas, that's right. Kathy Lorrea got it. Pancreatic is the cancer for which we're now recommending universal genetic counseling and testing. I always link counseling to testing because I think patients need to have their questions answered, and we oncologists have so much else to know. It's not possible for us to know absolutely everything. The third barrier is lack of information support. People have a lot of beliefs about genetic discrimination. They think it doesn't matter if they don't have children. They don't realize the Mendelian patterns of inheritance, and frankly, physicians don't either. So we're working on information support. And finally, there's an incredible lack of genetic counselors. There are approximately 600 genetic counselors who are skilled in cancer counseling across this country. And so we have a terrible shortage, and getting access can be quite difficult. We'll be addressing all of these within our new award. So the study AIMS has 3 questions and goals, one of which is exploratory. We're focusing on 5 cancers: breast, endometrial, ovarian, pancreas, and prostate. Can you see why I'm presenting this today? Because you get 2 out of the 5. At the practice level, we're trying to improve the quality of the family history. And the research question is, does a tablet-based family health history survey tool improve the completion of the family history. And this will be done in conjunction with genetics information support for oncology teams. A lot of these pedigrees, it's pattern recognition, but they're also advances all the time. And we feel that our job as a coordinating center is to help support clinicians, not just physicians, nurse practitioners, nurses, and keep people up to date with the changing guidelines. So we'll be doing that in the case of GYN oncology at the biannual meetings, as well as in between through what I hope are interactive tools. Any questions about that? Could I have people type in the chat what they think about this? I know I haven't given you a lot of information about the tablet, but I can do that while you find the chat. And this is a patient-completed questionnaire. They can complete it before the visit, at the visit. It can be done on an iPad or a phone. Terrific. So, Dr. Hannah, thank you. I'm happy you're excited about this. And it will also generate a PREM score, which helps us identify patients likely to have Lynch syndrome. Yes, it will be available in Spanish and in Arabic. So we're working on the translations now, and we'll be working with the health department to also run this through focus groups, because we want to make sure not only are the questions translated, but the ideas are translated, and that we're demonstrating cultural humility. So thanks for the feedback, everybody. Okay, so at the, oops, I have to go back up. All right, let's see. At the patient and family level, because patients, of course, one reason to do genetic testing is to identify at-risk family members, is to increase the proportion of people who get genetic testing. And again, that's along with counseling. Can we improve the proportion of patients getting guideline concordant genetic risk assessment and testing? Oh, yes. I'm hearing from Kelly Bristow that the age is not known. And helpful to, yes, we can always, if you can document in your family history that the person was diagnosed sometime in their 60s, that counts. That counts. And if you don't know the age, you have to write age unknown for that to be considered complete. If you write uncle had pancreas cancer or gastric cancer and you don't mention the age, that's an incomplete family history. If you say that uncle had what we think was pancreas cancer, and we don't know the age because he, left the country and hasn't been in touch with anybody, but we heard this on his Facebook page or whatever, that's fine. You just write age unknown. That makes it complete. So, okay, great. Thank you for that comment. All right, so the way we're approaching this is really exciting, and I think why we received the award. We're doing a 3-arm study of tailored messaging via a mobile optimized web interface. It's basically an app, but people who don't have a smartphone can still access this. We're very concerned about access. We're concerned about broadband access, and especially in rural areas. We're concerned about text messaging rates. We've already done a study with rural practices across Michigan. And one of the key findings from that, Dr. Hawley led that project through a supplement to the Rogel Cancer grant. We found that text messaging rates are a burden for some people. So we're going to be very mindful of that, because if you only let some people have access, you're reproducing inequity. So the 1-arm is, and this is randomized at the patient level once we know the patient's eligible for testing. If they've already been sent for testing, they won't be included in this because they've achieved their endpoint. But it's the remaining, 95+% of people who will be randomized to these 3 arms. So the app, genetic counseling with motivational interviewing, and genetic counselors all over the state will be training in motivational interviewing, which is a way of responding to patients' concerns and harnessing change language to help motivate people and clear up their information barriers, financial barriers, etc., versus usual care. Now, this doesn't mean patients randomized to usual care won't have the other resources available. So we are able to provide templates for you to send in with your patients who qualify for genetic testing or counseling and can't get it, we'll have appeal letters that you can download off the website. We're doing everything we can to help every patient get the best care. What we're testing is, are these new approaches better than the best we already have? And then the exploratory question. So the third question that I mentioned is, can we improve the uptake of cascade testing? That would really be its own grant unto itself. So we added this in to see if by motivationally interviewing the patients, can they apply the same, what they've learned and the same change motivations with their family members. What defines usual care for automatic referral versus nursing intake? Oh, especially in the case of ovarian cancer where it's automatic referral, we're not seeing that everywhere. So we are seeing that in this state, in the GYN practices, my biggest area where I think we're going to see a gap is in endometrial cancer. So I think that's, I'm not sure I'm answering quite the right question, but just so you know, I'm aware that there are automatic referrals, especially in ovarian. It's the other cancers that we're worried about. Or let's say you say a patient with ovarian cancer and her sister had a GI cancer at a young age and didn't have genetic counseling and testing. So that's the hope with a complete family history, as we start to take care of the whole family. All right, so the app, the content includes why should I get tested, knowledge, myths and facts, attitudes, norms, motivation, and behaviors. And we're also going to provide information on how to get testing, either through a genetic counseling practice, whether or not you have an on-site genetic counselor. And then there are also direct-to-consumer options, the results of which need help. Patients need help for understanding their results. And then also communicating with family. We're also going to have tips on how to do that. And this is all tailored to what the patient said is their concern. So it's not widespread blast information that people could get off the NCI website, for example. And then the function will be to give, as I mentioned, tailored content, reminders to follow up, communication tips with oncologists and primary care physicians. Like, remember that if you learn more about your family history, you want to update your doctor. I will tell you a story. I had a patient with lobular breast cancer, and I ask family history follow-up at every appointment. It's part of my routine questioning. And she was about 8 years out from stage 3 breast cancer, again, lobular cancer, and her brother was just diagnosed with gastric cancer. And that's a pedigree consistent with a mutation in E-cadherin. Patients who have a mutation in E-cadherin are actually advised to have prophylactic gastrectomy, which not a lot of people know. So this is the kind of thing that we want patients to be activated to do, is inform doctors of their new family history, and then we're supporting you in your practices to make sure you're as up to date as possible. And then we're also going to be able to provide information on where people can get testing in the state. So even if they live in the rural UP, we'll be able to give them information. And a lot more genetic counseling will be done via telemedicine. As you know, COVID switched us over to telemedicine faster than we ever thought would happen. And people won't need to travel 8 hours to see a genetic counselor. And then it will also have answers to frequently asked questions. So I would love to have people write in the chat any concerns you have about the project, any reactions.
Jennifer,
yes.
Dr. Gogoy from Carmanos would like to know, in the 3 arms that you described for the study, how would you define usual care?
Well, that would be what happens without any intervention. Now, of course, everybody's going to be updated in terms of what the guidelines are for testing, who and when. And so usual care is actually going to be enhanced compared to what it is right now, but it will be exactly what Dr. Gogoy asked: automatic referral, that counts, versus nursing intake, that counts. So whatever your standard practice is will count as usual care. I had tried to answer that before, but maybe answered a different question. And then I think Dr. Mize also has a question.
Actually, that was just my toddler who accidentally pushed a button.
Oh, okay. Well, welcome to your daughter. I have a puppy who comes in flying through my camera sometimes. All right, so if you could go to the chat or go to if you go down to the bottom of your screen and hit reactions, you can clap or smile. Yes, Dr. Upal made a good point. The rates of cascade testing might be lower in usual care versus the other arms because usual care doesn't activate patients or overcome their barriers. Oh, good. Thanks for the thumbs up. Amanda, awesome. Thanks for responding with a thumbs up.
Jennifer, there
Yes.
may be some people on the call that may not be really have a good understanding of what cascade testing is.
Oh, thank you for raising that question. Cascade testing is testing of at-risk family members. So your siblings, your parents, a lot of people ignore their parents, but as we know, the age of onset of a BRCA-associated breast or ovarian cancer can be later than in the proband, than in your patient. So your patient comes in, she doesn't have children or siblings, don't forget her parents. So that's called cascade testing. I guess cascades can go up and out and down. All right, I'm not seeing any other comments, so maybe we want to unmute everybody and open it up, or I'll let Vanessa lead it. She's a good driver. Or we might be done.
Well, I do think unmuting everyone. Go ahead and everyone start unmuting yourselves, and we can start talking more openly.
Dr. Christie asked, how do practices get involved? We will be rolling this out in what's called a cluster step wedge design. So based on basically our capacity to bring practices on board, will be done over time, and we're going to most likely stratify by baseline family history performance. So for a GYN onc practice, we haven't been collecting this measure, but we do know how Karmanos as a whole is doing on family history, and I'd be very happy to share that with anybody. So we'll be reaching out to you. Hi.
One of my questions was, in our Middle Eastern population, what I've experienced is them not amenable to talk about the potential of having a genetic mutation because that could affect their likability for future relationships. Has that been factored in some of these populations that have a different cultural, for lack of a better word, normal understanding of genetic mutations?
Yes, thank you, Dr. Hanna. The question was about our Middle Eastern populations and the stigma of being known to have an inherited susceptibility to cancer. One of our key things that we're doing is making sure everything we create is based on information from the group. So it starts with listening. Dr. Reznicka, one of the co-PIs on the project, has done a statewide survey of MENA populations, so Middle Eastern, North African populations, and we've looked at knowledge, attitudes, and beliefs about genetic counseling testing and being found to have a mutation. So all of the materials will be tailored to people in their culture, where they sit. Otherwise, it would be, I think, a form of structural violence not to do that. That's what we're going into all of our population-based interventions with an approach of humble inquiry where we listen, and then we make sure we don't widen inequities through what we do. Often what happens is new technology widens inequities in care, and this is something about which we're extremely mindful. One of our genetic counselors who's working on the project is Middle Eastern and can deliver, therefore, counseling in people's native tongue, depending on which dialect they speak. We don't have a Chaldean Chaldean-speaking genetic counselor yet. And by working through the health department, we'll be able to run focus groups on everything that we're doing. I just want to mention that we are building information, for example, for the ovarian cancer project, and the health department will be running focus groups for every piece of information that is created for your project, and including for trans people, because people who are trans may not identify as women, yet they still have ovaries and a uterus, for example. So again, it's a form of addressing structural violence. And then I have a question from Kelly Bristow. Would this be a HIPAA violation going through a health information exchange to find relatives? I don't know if Debbie Webster is, oh, Deb, you're still on. Do you want to unmute yourself and talk about how the state is able to help with cascade testing information? You're still muted.
Okay. So there are 2 different sections of MDHHS that are working with you. And so I'm assuming you're talking about cascade testing working with our genomics section.
Yes.
And I am not completely in on that project, so I can't give you a lot of information.
All right.
I apologize for that.
So my understanding is, I don't know if Dr. Stoffel's on the phone. She's the genetics expert. She's a gastroenterologist and also an expert in genetics. But the CDC has granted our Michigan Department of Health and Human Services with a genomics grant. So when I say partnerships with the state, I mean, we're really working with one of the top health departments in the country. And there is a way for us to identify cascade testing in people living in the same state. So it's not a HIPAA violation. And I wish I could speak to the particulars of why not, but that's a great idea to harness the health information exchange. And this will help us meet our 3rd research question, which was going to be a key research question, but it, like I said, in itself, it can be its own 5-year project. So it's, can we get a signal that we're improving cascade testing through this grant? I'm just going to scroll through page 2 of people attending. All right, I don't see any other hands, so I'm going to turn things back over to Vanessa.
All right, great. And I'm in turn going to turn things back over to Shitanshu so that he can talk about next steps on the MOQC side.
Okay, so I think before I go into the next step, there's something I wanted to show everybody. This our team has seen this resource. Let me share my screen so everybody can see it. So this resource, we started this, well, basically out of the boredom in the first few weeks of COVID. I could not do the teaching for our fellows, so we put up this website. So you might want to bookmark this as well. It's called gyoedu.org. So if you go on this website, this is an educational series which has been running for now about 2 months. This has become very popular around the world, actually. I have Google Analytics on this website, and I was able to see that people in Middle East and India and Australia and New Zealand, they were all using this website. So just to give you a little overview of what this website is, this is not related to MOQC, but I think it can improve quality of care in a couple of different ways. So we started this for fellows, where I invited a few of my colleagues around the country and said, we are in a difficult position where we can't have our regular didactics. Would you be willing to give a lecture on Zoom? And then we recorded all those lectures. So if you can go to the past lectures, there are about 20 lectures available right now on all sorts of topics. You can actually click on this page over here, see all the videos on a single page. And you can watch these lectures by a lot of GYN oncologists around the country on chemotherapy emergencies, early stage ovarian cancer, advanced stage cervical cancer. This is Kathleen Moore who's given this lecture and talks about all the clinical trials which have been reported in the last year and a half. A few of the lectures on genetic testing and endometrial cancer specifically.
I'm so sorry. I'm just going to interrupt for a
Yes.
brief second. Shitanshi, we're
Unless-
not seeing the website.
Oh, sorry. I think it's
Yeah.
me because I might have changed the screen over here. Okay, is it visible now?
Yes.
Okay, sorry, my bad. This is the GYO-EDU website, and then you can go into the past lectures. And in the past lectures, this is the link over here. You can either use a player here or go to this link, and you can see all the 20 lectures which have happened. Firmovich just gave a lecture on sentinel lymph nodes. I mean, you know, this is a fantastic lecture. In about an hour, you'll know everything about sentinel lymph nodes you need to know. In addition to that, we have this link over here, upcoming lectures, so you can see what is in the pipeline. Dr. Gogoy is going to be talking about cervical dysplasia and HPV. One of the lectures was given by Dr. Morris early on about uterine papillary serous carcinoma. So if you have an interest in giving the lecture, you can go up to this link called sign up. And there's a link here, faculty to sign up for lectures. So when you click that, it will just open a Google Sheet. These are the list of lectures which need to be given. These are the dates which are available. So you can put your name in there and be ready to give a lecture. The other piece in this website, which is amazing, is that we asked our fellows to summarize the key clinical trials in GYN oncology. So if you go to the study summary section, it will open up this database which has been created, and now it has 74 studies. So if you scroll down on this database, you can see every single one of these studies by a grouping. So you can see uterus and surgical studies. So you can look at this Mayo Clinic 2000 key study and hit this arrow over here, and you can read all about this study over here. You know, limitations, conclusions, results of this study. So if you wanted to see, you know, what about the FIRES trial, for example, we were talking about earlier, you can go into the find here and say FIRES. And it will bring you up to the FIRES trial, and we can open it up and see that the FIRES trial, this is a publication link over here, publication title, hypothesis, the experimental arm, and the results of this trial, what were the exclusion criterias, and the conclusion of the trial, and limitations of the trial are all here. So the key 74 trials are listed over here, and these tags over here help you find what exactly what you're looking for. So if you have a patient who you're giving chemotherapy, for example, GOG 240, you can just type in GOG 240, and here it is. And you can just open it up, and you have the summary of GOG 240 in 2 clicks. So this can help you find the key GYN oncology studies really quickly. Over time, my goal is to create a much better version of this website, which is mobile friendly. This one is not mobile friendly right now. So we're working on that. I think that's pretty much what we have right now on this website. We're also trying to bring in some content by the disease, where we'll talk about the management, NCCN management of these cancers. So that's all I have. Okay, so I think we are open to questions. As anything related to quality improvement, anything we should be thinking about as our future quality improvement projects. You know, I'm excited about the possibility of looking at immediate surgical outcomes from MSQC, but we're open to suggestions here.
Anshu, that's really terrific. This is Jennifer. That's just really impressive and a great resource. The lecture series you've put together is amazing.
Thank you.
Yes, Ben from the west side of the state thinks the same too, Shatanshu. He loves it.
Okay, so I think if we don't have questions, then we could conclude earlier. Anything else on the housekeeping side, Vanessa, Louise, we need to talk about?
No, just remember that that there are CME credits available, and the instructions for how to claim those CME credits are in your electronic materials, and the link for that is included in the agenda.
Luis, you're mute right now.
One of these days I'll get this mute unmute function sorted out. So we will send out to everybody a brief summary from this meeting that will also include the follow-ups in terms of where you can volunteer, what we're asking you to volunteer for, links. So it'll all be in one email for you. And you're not going to agendas and this email, that email. So don't worry. I've said through the chat, we'll have a summary email. So, and you'll get this deck so that you will can reference it and you can share it with your colleagues for those who have somebody, more than one surgeon within their practice. So you can look forward to that. We will also be sending you the laminated op note cards that Vanessa referenced, but that will be coming by snail mail. So you can look for that in about 7 to 10 days.
Okay, and if anyone, you're all welcome to unmute yourselves to just say goodbye and let us know if you have any additional thoughts.
Bye.
Hi, Amanda, I see you there.
You guys, thanks a lot. Appreciate it.
Great.
Thank you. Thank you all for coming.
Thanks, guys. Bye.
Hi, Rebecca.
Thanks. Appreciate it.
Bye, everyone.